Perfect. Excellent. All right. It is another Wednesday, and it is another CWIS case review series for the month of May. Welcome, everyone. Depending on where you're logging in, it's either morning, afternoon, or evening. But we are excited to have you here for another great series of presentations. Before we get started, just a couple of rules of engagement. First and foremost, we strongly encourage questions. The presenters oftentimes are bringing their cases here specifically for questions. So please feel free to put questions in the chat, and once the presenters are done, we'll open it up for questions from the audience. The more conversation, the better. For people viewing the talks, please make sure you're on mute during the presentations. The way you're going to know you're on mute is if there's a little red microphone with a line through it on the bottom of your screen. Then just a reminder, the format is 5 to 7 minutes for the presentation. We have 2 presentations today, so one of the presentations will go a little bit longer, and then 5 to 7 minutes afterwards for questions for each of the presentations. And then just a reminder at the bottom, please remember to register for the next CWIS case review series on the link below. And just a reminder that all of the CWIS case series are available for viewing pleasure on that same site. So with that, I'm going to stop my sharing, and I'm going to hand it over to Dr. Kovi Bessoff, who is a PGY4 resident at Stanford for the first case. So Kovi, if you want to share your screen and take it away.
Good morning, or afternoon, or evening, depending on where you are. Can everybody see my screen?
We can.
Excellent. Let me just go into presenter mode here. All right, so thank you very much for the opportunity to present. I'll be discussing today a case of surgical stabilization of rib fractures in an octogenarian. So very briefly, this is an 86-year-old male who over the past months had multiple falls. Most recently, though, he was admitted to, presented at an outside hospital 2 days prior to when we met him following one of these falls. And he was discharged from that emergency department with a diagnosis of rib fractures, T-spine and T-spine end plate fractures. However, his pain worsened over the next 2 days, and at the behest of a physician friend, he returned to our ED with persistent left-sided pain. Cross-sectional imaging in the ED revealed a pretty impressive left-sided chest wall injury and a hemothorax for which a chest tube was actually placed in the emergency department. He was ultimately admitted to our ICU via our rib fracture protocol for multimodal pain control, which included narcotics, lidocaine, nerve block. Unfortunately, this patient had persistent numeric pain scores greater than 5, poor inspiratory effort as measured objectively by IS of greater than 750, and was also noted to have a weak cough. Just a couple of important past medical history notes. This patient had a history of paroxysmal SVT and also a pretty significant history of COPD. He was a 40 pack year smoker. Baseline oxygen saturations were in the low 90s, and he was sort of moderately adherent to his home regimen of inhalers, which included albuterol, diltiazem, and a no longer acting inhaler. So, as I mentioned, he had a pretty impressive list of thoracic injuries, which included left 2nd through 8th rib fractures. Of note, ribs 4 and 8 were displaced, ribs 6 and 7 were comminuted, and rib 5 actually was broken in 3 separate places. This is a 3D rendering on the right of his chest wall injuries with both an anterior and a posterior view. He also had a large hemothorax, as discussed, and intraoperatively was noted to actually have a lung laceration from one of the rib fragments. So after much discussion, attempts at optimization, and sort of collaboration with our geriatric service, the decision was made to take him to the operating room for surgical stabilization and intercostal cryoneurolysis. This happened on post-injury day 2. We made a posterior longitudinal incision exposing the auscultatory triangle, and as always performed muscle splitting to try to minimize the degree of actual division of the muscles. Upon exposing the fractures, it was noted that these fractures were significantly more severe than expected, even based on the 3D renderings and cross-sectional imaging that I previously reviewed. Ultimately, we performed ORIF of ribs 4, 5, 6, 7, and 8. Of note, the fifth rib, as I mentioned, had 3 separate fractures. So it was actually plated in 2 different places. The first plate was able to span 2 posterior fractures, and then he had a much more anterior fracture, for which we used a second plate. A total of 6 plates were used. We tend to use a unicortical plating system and 102 screws, just to give you an sort of impression of how significant this gentleman's fractures were. We then went on to perform VATS, and as becoming more and more standard in our practice, performed cryoneurolysis of ribs 3 through 8. And then at this point, we did note that the patient had a left superior lung laceration, actually from one of the rib fractures, that we actually gingerly took off the rib piece and left a couple of chest tubes after doing washout. This is a post-operative chest X-ray. And then post-operatively, the patient was admitted to the ICU. He was doing well and was transferred to step down on post-operative day 2. However, on the floor, he had a mucus plugging event and was transferred back to the ICU following a rapid response team protocol given low saturations on the floor. He was treated there for a COPD exacerbation and fortunately improved pretty quickly and was transferred subsequently out of the ICU on post-operative day 3. At some point, he was actually COVID positive in asymptomatic fashion, given that his daughter was positive. Patient did have a persistent air leak. We believe was secondary to his known lung puncture. This was actually treated with a blood patch, and that sealed, and he had no subsequent issues there. Finally, he was discharged from our hospital to a skilled nursing facility on post-operative day 10, but was readmitted shortly thereafter with a COPD exacerbation. He was treated again for his exacerbation, and a pneumonia was started on levofloxacin and was discharged back to his SNF on post-operative day 15. He was recently seen in clinic and follow-up, and as you can see here, is doing very well. Very excited about his new hardware and is breathing well. Pain is well controlled. So just a couple of learning points to talk about. One is surgical fixation in elderly patients. This is the oldest patient that we've done in our series, and I imagine is probably pushing the upper limit of age for just about anybody else's experiences, though we'd love to hear otherwise. But so importantly, I think some important things to think about here is that rib plating is in fact feasible in the elderly patients, provided that these are good surgical candidates, that there's a multidisciplinary evaluation of comorbidities. And then one tool, sort of a shameless plug for our group that I'd like to make here, is that Jeff Choi, who's another one of our residents, recently developed the Rib Fracture Frailty Index, which provides some objective data based on NSQIP modeling regarding potential outcomes for associated with elderly patients with rib fractures. So there's a publication that's coming soon, but there's actually an app available for wide use. It's available for iPhone now and hopefully Android soon. That can be downloaded from the App Store. It's called the RFF Index, and here is actually a screenshot of that on the right side. And then we have plans moving forward to do additional research to try to correlate the frailty index with surgical outcomes, specifically for surgical fixation. This is the table from Jeff's publication upon which the index is based. So just to give you an idea of some of the inputs here that the calculator takes into account. And finally, just wanted to talk briefly about cryoneurolysis as an adjunct to pain control. I believe that it's sort of starting to pick up, though I'm not sure how widely used it is. We've really been routinely using it to treat intercostal nerves 3 through 8. Just a little bit of background on the approach is that it induces second-degree Sunderland injury. So what this means is disruption of the axon itself within the myelin sheaths, but it leaves the perineural tissue in place. So this promotes Wallerian degeneration. in a injury to distal manner, which promotes long-term durable pain relief on the order of months, but ultimately allows for nerve regeneration. We've done a retrospective study, which is hopefully coming soon, has been submitted and is under review, where we looked at 34 patients. Our conclusions are that this is a safe technique, though the study was likely underpowered to show a quantifiable benefit as a pain adjunct. So it's really what I have. Thank you again for the opportunity to present. Happy to take any questions and to hear some discussion.
Excellent. Thank you, Covey. While we wait for some questions to come into the chat, I guess one question for you as house staff is, when you're thinking about these patients coming into the ED, you guys are oftentimes like the first responders. How are you talking with patients about the risks and benefits of this procedure, particularly in someone who's, an octogenarian or potentially even older?
Yeah, no, it's a great question. I think in general, we really tend to focus on the pain control situation. Just speaking in general to patients, the importance of managing pain control adequately to be able to promote deep inspiration, prevent pneumonia. So I really kind of try to frame it in that context, but also that surgery may actually do a good job in preventing your short-term pain control. However, when you start speaking to older patients with additional comorbidities, I think it is really important to have a frank discussion regarding those comorbidities. But as we've seen in this sort of the rib fracture index is trying to quantify, those are the same comorbidities that are going to make their hospital stays longer and more difficult. So I think just a really frank discussion on that is important.
Awesome. And then seeing a question coming in from the chat from Dr. Erickson, which side plugged, operative or non-operative side, and do we routinely bronch after each case, and should we be?
So I believe it was the operative side, if I remember correctly. And we actually don't routinely bronch after cases, though this may be a patient who would have benefited from that.
Okay. We're seeing if any more questions are coming in from the chat. Not seeing any. Thank you, Covey. Why don't you go ahead and stop sharing? Oh, actually, there's one more question before we move on to Dr. Erickson from Dr. Bacon. You mentioned nerve block as an adjunct. Do you do intraoperative intrathoracic block in addition to cryo?
Yes, we do. And the reason for that is because the cryo typically takes about 24 to 48 hours to begin to gain effect. So in the meantime, we do nerve block as well. The nerve block for this patient that I had mentioned was actually prior to surgery, though our anesthesia colleagues will provide either our regional team or sometimes even an epidural. So they'll place either an EPS catheter or an epidural catheter. And then occasionally our ED colleagues will do a serratus block. So we do tend to separate those two approaches, but we do an intraoperative block as well.
Excellent. Thank you, Covey. And then the gauntlet has been thrown down by Dr. Erickson, who says that 93 is his oldest patient. So we have work to do.
All right, we can do that.
With that, I'd like to turn the presentation over to Dr. Erickson, who is the Trauma Medical Director at MUSC and the Director of their Chest Wall Injury Center. So Dr. Erickson, we'll hand it over to you.
Perfect. Thank you very much. Let's see if I can figure out how to do this share screen business. You guys see a PowerPoint?
We do. Looks great.
Awesome. Okay. I'd like to thank you guys for the opportunity.
Everett, sorry, it's on the like presenter view.
Oh, all right. Let's see. You'd think after this many.
Do the same thing again. Yeah, go back to that one.
Is that right?
Yes.
All right. You'd think after a year and a half of this, I'd figure out how to do this business. Well, thank you guys for the opportunity to present this case. This is a little bit of a different case and a different approach than we traditionally do at these. I'm looking for some help on a case. This is a case that I'm sharing with my orthopedic surgeon, Dr. Wolf, here at the Medical University. He's one of our shoulder surgeons, and he participated a lot in this patient's care initially, and now she's kind of become a multi-surgeon entity. So let's kind of get into it a little bit. So this is a 54-year-old female. She's really quite healthy with the exception of having spastic diplegia, which is a subtype of cerebral palsy, where the legs are usually the most affected limbs. However, she has had a lot of effect with her right upper extremity. She's on Valium and baclofen for the spasticity. She had a reverse shoulder arthroplasty done in February of 2020. And that was done to improve mobility in her shoulder. It was becoming somewhat seized, and that was her dominant arm. After that surgery, she recovered well and had kind of a slow physical therapy recovery, but given her CP, she was making reasonable progress. And then in May, she developed a chest wall radiculopathy. She had radiating pain around the right side of her chest. They worked her up for this and via MRI found a mid-thoracic stenosis at T5-6. She failed medical management with Neurontin and physical therapy and different adjuncts, and ultimately went to surgery for a laminectomy and decompression with neurosurgery of the herniated disc. This really didn't do anything to improve her radiculopathy. She continued to have a dermatomal pain sensation across her chest wall. And Dr. Wolf ultimately referred her over to me in the rib clinic to see if there was anything to do with her. Incidentally, she was also noted to have some rib fractures pop up on her CT scan of her chest that was done during her radiculopathy workup. When I saw her in clinic, she continued to have a grinding feeling with movement of the right upper extremity. She had no history of trauma to the area other than the surgical interventions to her back and her shoulder. And she had a radiating radicular pain in what I felt to be a T3-4 distribution, which corresponded with the location of these rib fractures that we saw. And we did a rib 3-4 local injection with some mild improvement in pain. Now, if we look at her CT scan, what you see as we come down on the right side, she has this rib fracture on the third rib here, as well as a fourth rib fracture right in this location. The other thing that we noted on this was a little bit of prominent hardware from the shoulder arthroplasty here, although we weren't sure if that was prominent or not, as we don't routinely get CT scans after reverse shoulders, and likely these screws are into the subscapularis muscle on a regular basis. When we look at her in another window, you can see that the hardware is close to the chest wall, but not necessarily impinging on the chest wall up in this location. Really didn't appear to have any periprosthetic fractures of the shoulder area, but those couple rib fractures. Now, sorry. A little further down the road, let me see, is this the right? Here we go. Back in February of 2021, we got another CAT scan. And this CAT scan was interesting in that it showed a spontaneous hematoma formation along the chest wall, just inferior to the shoulder arthroplasty and overlying the fourth rib that had the fracture. There's also a slight calcification in it that you can note there. And again, when we look at it in another dimension, you'll see this hematoma up under the scapula, close to the fourth rib fracture, and the hardware overlying it, but the hematoma just inferior to the hardware location. So March of this year, We did cryoablation of the third and fourth rib nerves, as well as cement fixation of the fracture lines at 3 and 4, ethanol ablation of the third and fourth ribs, and we biopsied that calcified mass that was under the scapula. Her pain improved a little bit, but she continued to have pain underneath that right arm. It improves with a dose of steroids, a Solu-Medrol dose pack, but then the pain returns as soon as she's weaned off of pain medication. Her most recent CT scan is here. And what you can see is she's having some healing of her rib fractures, and that hematoma or mass under the scapula has decreased in size considerably, but that calcified mass has sucked down onto the chest wall right there. As you can see it right in here. So the question that I've got for you is, what do we do with this woman? Is her pain from her shoulder implant? Is it from the mass on the chest wall, or is it from non-unions of her rib fractures that are causing the pain? And how do we address that? And, oops, sorry. There's the location of that calcification again. So the question I've got for the panel today is, should we operate? If we operate, do we go after the scapula, the ribs, or the scapular mass? From an approach, how do we get there? Do we go lateral? Do we go through the axilla, or do we go through the triangle of auscultation if we're going to go after the subscapular mass? Or any other ideas for you? Or is the best thing we got medical management, steroids, and serial injections? And that's what I have for my presentation. I'd welcome any questions, comments, or guidance on this.
Thank you, Dr. Erickson. This is definitely a challenging case, and look forward to seeing what thoughts people have coming in from the audience. As kind of just looking through it, I guess two questions from me. What do you anticipate the bone cement to look like on CT scan? Like, do you think that calcification that you see around the ribs could actually be some sort of reaction to the bone cement on ribs 3 and 4?
Sure. So it could be a reaction to that. I didn't include the pictures from that. Based on the CT images, they did CT guidance with putting in the bone cement. It's considerably larger than what they put in. They put in very small aliquots of bone cement into the non-union location within the fracture itself. So it's a whole lot more calcification there than can be straight attributed to the bone cement itself. Now, is it a local reaction that the body's depositing calcium? Possibly. But I'm not sure why there's that mass off of the chest wall. I would assume you'd get hypertrophy and extra calcium deposits at the level of the rib, not necessarily along the chest wall in the subscapular bursa area.
Okay. And then it looks like Tom says, I'm unable to give your case full attention, but he's going to review the recording and get back to you. So we'll have some additional thoughts coming in there. One other question for the neurologist. I guess, have you talked with your neurologist, and do they see kind of more unexpected inflammatory reactions for these patients that get hardware put in? Like, is there any sort of medically explainable reason why she's having more inflammation than normal?
Not that we know of. And I talked to my orthopedics guys as well as the spine surgeon that worked on her. And they said they really don't tend to see different reactions from this patient population than their standard populations when they do the operations.
Okay. Yeah, I guess just looking at the images, it looks like some of those, those two screws for the arthroplasty look like offending agents. I'm sure the orthopedic surgeon might be less enthusiastic about going in and removing them, but it certainly looks related on the CT scans that we're able to see. I mean, those two screws are real close to the chest wall.
Yeah, and that's something that we're kind of struggling with. One, going in and taking those screws out or revising that shoulder may be extremely debilitating for her. And there's not a great way to get at those screws from the underside and shorten them or cut them back. There's not good cutters that we can get in a minimal access approach or anything like that to take care of those. We may be able to get a good enough exposure through an axillary incision, but that's going to be a big incision around a bunch of nerves and whatnot that we all learn to avoid in general surgery class. But going up there and retracting all that to get access may be a bit of a challenging case, and getting there from the auscultatory triangle is a long way.
Yeah. It looks like there's a question from Jesse. Is it an option or routine that you use cement on your non-union fractures, and how is your outcome with cement for non-unions?
So we don't routinely use it. This is actually the first patient that I've seen it occur on, and it was one of the people who helped us out with this case is one of our new interventional radiologists. So that's kind of a new technology for me, and we've been kind of discussing what patients that might be appropriate for, but I don't have really any experience with that for non-unions.
I guess one other question. Have you thought about actually just removing the segment of rib that's under those two screws, if the screws are going to be that hard to take out? I mean, it's not ideal because it's going to affect our chest wall mechanics, but it may prevent, something like at least hitting the rib, which may be setting off that nerve.
Yeah, it's an interesting idea. My thought was if she responded really well to the nerve injections or the neurolysis, that I would consider doing something from a rib perspective. With only marginal improvement with the neurolysis, I've been a little reluctant to doing anything from an operative perspective. The scapula also relies on some of that integrity of the chest wall to slide against the rib cage itself, and removing those could potentially increase problems if the scapula starts sticking on that rib end of the third or fourth in that location.
All right. Do we have any other questions coming in from the chat? Give people a minute here. Maybe Dr. Erickson, do you want to put your email in the chat in case people are reviewing this in the near future on CWIS, and then they can hit you up and send you any questions?
Sure, I can do that, I think.
And then while you're doing that, it looks like Jesse has a second point that agrees with you about how complex the case is, and pain may not only be from the ribs, but also the calcification or inflammation beneath the scapula.
Yeah, it's definitely not an easy one. We've been thinking quite a bit about it, and reached out to some other experts from around the nation, Dr. Cole and some other orthopedic guys, to kind of look at the shoulder and everything that's going on there to get kind of all the opinions we can get before we dive into fixing anything or attempting to fix anything.
Excellent. Well, I'm not seeing any other comments coming into the chat. However, we'll get this posted up on the website probably by later today. And we can hopefully get you some additional insight and comments coming back from the rest of the group, because this is definitely quite a challenging case. So we look forward to seeing what ends up coming of it. So please feel free to come back and present in the future once you have a solution, because I'm sure we'll all learn from it.
No, that's great. If you don't mind, I have one other question for the group, and it kind of goes along the lines of the questions that I had for y'all's case. Is anybody seeing mucus plugging on the contralateral lung after you pull them out of lateral? We do postoperative x-rays in the OR on every single case. And I've found some evidence of collapse on the contralateral side on that immediate postoperative chest x-ray. And I'm wondering if I ought to be bronching everybody if they don't kind of drain stuff from the contusion and whatnot with postural drainage after sitting in the OR for a couple of hours while we're doing the chest wall reconstruction, where we need to evacuate some of that stuff. And just wondering if anybody else has had that same experience, or if anybody x-rays in the OR and has noticed de-recruitment on the contralateral side.
I'd say from us, we do post-op chest x-rays in the PACU, not routinely in the OR. I can't say that I've noticed anything, but we can definitely go back and look. We don't routinely bronch either, but we also, our single lung ventilation is for a fairly short period of time. So we're basically just doing single lung when we're doing the VATS for the intercostal cryoneurolysis, or washing out whatever hemothorax is in. So like our single lung time is probably less than 20 minutes for the vast majority of the cases.
Gotcha. And I don't single lung at all. I do a single lumen AT tube on all the cases.
Gotcha. And then to Dr. Zagan's question, we will be posting the case review series on Slack. We can see if Dr. Erickson is willing to put up his patient case on Slack as well.
Yeah, we can look at that.
Awesome. Anyone else have thoughts, comments on postoperative bronchoscopy in these patients? All right. Not seeing any other comments. Maybe we can put that up. I think that'll also be a great question for Slack too, and see if anyone probably get a quick survey result and see if anyone else has thoughts. All right. Well, with that, I want to take the opportunity again to thank both of our presenters today. Dr. Erickson, appreciate you being willing to present on such short notice. So thank you again, and hopefully we'll be able to get you some additional thoughts and comments once this posts on the website. And again, just a reminder to everyone, the case review series links are available on the CWIS website. All of the old case review series are available there for your viewing pleasure. And also just a quick shout out for the riblets and the ribcast. Make sure you're checking in on those productions because it's a great way to get an additional chest wall fix during the week if you're not able to make the case review series. So once again, thank you, Dr. Erickson. Thank you, Dr. Bessoff, and we'll look forward to seeing everyone next month for the case review series.
Thank you.